विश्व में हमने युवाओं की आईटी एनर्जी के माध्यम से अपना एक रुतबा खड़ा किया है और भारत इसके बाद के लिए गर्व कर सकता है। दुनिया में हम आंख में आंख मिला करके बात कर सकते हैं। और ये मेरा साथ मैं हमेशा कहता आया हूं, आईटी प्लस आईटी इज इक्वल टू आईटी। इंफॉर्मेशन टेक्नोलॉजी प्लस इंडियन टैलेंट इज इक्वल टू इंडिया टुमारो।
Namaskar and very warm welcome to all of you in the second edition of Radiology and Imaging Summit of ELITS Technomedia. And I'm truly overwhelmed with the speakers today who have joined us. And I warmly welcome Dr. Shilpa Lad, Consultant, Breast Imaging and Interventions, NM Medical Center. Very welcome to you, Madam. Dr. Rupa Anantasivan, Consultant Radiologist, Manipal Hospital. Dr. Bhagyam Raghavan, Senior Consultant Radiologist, Apollo Specialty Hospital. Dr. Tanvi Jaki, Consultant Radiologist, Mammocare. Dr. Rita Dhruv, Partner, Prabha Telesolutions LLP. Dr. Bhargavi Venkat, Radiologist, Koshish Hospital. आप सबका बहुत बहुत स्वागत है आज के एक बहुत ही महत्वपूर्ण सेशन में। एंड आई होप आज आप सबकी जो भी टिप्पणी रहेगी वो हमारे सारे ही दर्शकों के लिए बहुत ही लाभदायक और बहुत ही यूजफुल रहेगी। सो विद दिस आई हेमांगिनी, senior editor, ELITS Technomedia, would like to hand over this session to our today's moderator, Dr. Shilpa Lad, and we request to take this session further. Dr. Shilpa Lad.
Thank you so much, Hemangini. Thank you to you and the entire group at ELITS for giving us an opportunity to speak about a cause which is so close to the heart of every single person present on this panel today here. So I welcome all my fellow panelists to this discussion, and without further ado, I would like to share a case with you guys so that we can take this discussion further. So just give me 1 second here. Okay, are you able to see my screen? Hemangini, can you unmute and tell me, please?
Yes.
You can see it, right? So this is a quote I came across on Instagram a while back, which said, whenever you are in the middle of a tunnel, you can't see the light on either end. And that's what COVID feels like. It's like you really can't see the light on either end anymore. So you're just in the dark. And this is exactly what is happening to our patients, our women who have breast symptoms and they want to come to the hospital, okay, but they are afraid, okay? And all this is having a severe impact on breast imaging and interventions, and hence on patients' presentation and the outcome. So here is a case that I would like to share with all of you. This is a 36-year-old who presented in the last week of May with an enlarging palpable lump in the right breast since 3 months. She had noticed the lump. She had felt it, but despite of that, this young, smart, professional women decided to stay home and not go to the hospital. Why was that? Because COVID was raging in the month of March. People were either looking after their near and dear ones or hearing horror stories. Therefore, they were afraid to get out of the house. And this is exactly what this patient said. When we did an ultrasound, this is what we found. Irregular hypoechoic solid mass, which was 5 centimeters. At presentation, a tumor of 5 centimeters in this young woman. This was eventually biopsied, and it turned out to be a high-grade cancer. Okay. Now, this is what we were presented with, which also took us back to our own data. We decided to compare what happened in pre-COVID times to what was happening in COVID times. What were the number of biopsies we were doing at our center in 2019 versus 2020 for suspicious cancer cases. And what we realized was in the month of January and February, our numbers were way more in 2020 as compared to 2019. Okay, so more and more women were getting aware and coming to the doctor in time. However, in March, when the lockdown hit us, the number of biopsies went down, which went even further down in the month of April. Means women who had symptoms decided to stay home. Okay, in the month of May, it started picking up eventually from May to June. And then eventually last year in July, it finally started normalizing. However, this year again, we saw similar trends of the number of biopsies going down. And all this was because of the impact of COVID. Okay, so here are some questions for our panelists. Okay, I'm just going to stop screen share here. Okay. Now I've stopped my screen share, and I would like to ask Dr. Rupa, this is what we were noticing at our own center. And my question is, were there similar trends at your institute in Bangalore? And were there similar situations that you were coming across?
Thanks, Shilpa, for that wonderful case. And that actually was an exact deja vu, because that's the sort of things we've been seeing immediately after the lockdown. It started last year. We've actually looked at our data also, and it's very similar to yours. We had a huge number of patients coming in January and February and March of last year. But as you know, a tremendous dip in number of cases in April. And then when things started opening up again in maybe June, we had all these cases, suddenly building up. So we had definitely, we had cases like yours who had noticed a symptom, but were delayed in coming for evaluating that symptom. We had patients who had a symptom and were half evaluated. They must have done an ultrasound and they were suggested a biopsy, but then again, they got 6 weeks delayed because of that. We had patients who had been diagnosed and were asked to come to the hospital for the chemo or whatever, and that also was delayed by 6 weeks. So similar, we found a delay not only in diagnosis, but also in taking things forward. Okay, and this was most in the last lockdown. This time we are a bit better. Of course, we did see a dip in this lockdown too, but perhaps women are realizing that it's really not a wise thing to delay something which will impact your health and your life. And so the number of biopsies, though it took a hit and a dip in this lockdown also, it's not as bad as the last lockdown. We've just opened 2 weeks after lockdown, and already we are seeing those cases coming in. In this last 1 week, we've seen big cancers, women who have cancers with lymph nodes, and you wonder, oh my God, if this lady had come 5 weeks ago, just before the lockdown, maybe this lymph node would not have been there. So definitely, this is exactly the same trend we're seeing. And as it is, our numbers are bad. We know breast cancer, the numbers in breast cancer in India are bad. 1 in 5 women actually die. 1 in 2 women actually die of breast cancer, unlike in the West. Okay, more than 75% of our cases actually come in stage 3 or 4. 50% come in stage 3, which is not a good number. And so this will just be compounded by the lockdown, by the pandemic, and also by the economic distress and, and the family responsibilities that a woman would have during the pandemic.
Right. So a follow-up question to that, like just to make our audience understand, what do you mean by the lymph node got involved? How does it impact the patient? If you found the same cancer when it was 2 centimeter without the involvement of the lymph node, how would the management have been done? And with a 5 centimeter mass with a lymph node, how does the management differ?
So definitely the type of treatment and the survival depends upon, one, the size of the tumor. It also depends upon the aggressiveness of the tumor. We won't take that in. It depends upon the size of the tumor, and size does increase as the disease progresses. So the earlier you come, the smaller your lump will be. Definitely. Okay. As it grows bigger, the breast cancer will have to spread out. The cells come out of thing, and the first place it goes and lodges is actually the lymph nodes under the same armpit. Okay. So that automatically changes the stage. So if you have a woman who comes in with stage 1 disease, which we mean a small lump less than 2 centimeters with no spread anywhere, no enlarged lymph nodes in that armpit, she has actually 98 to 100% survival rate. Okay. But as it goes down, especially when you come to a mass, what we call locally advanced breast cancer, where you have a mass which is more than 5 centimeters, which may or may not have involved the skin, because in early stage 3 it may not have, but which is already spread to the lymph nodes, and at least 2 to 3 enlarged lymph nodes are seen. The survival rate suddenly drops to about, they say about 70%, and 70 to 80% even in that stage, but I really believe it's only about 60%. So you have a sudden drop of 40%, okay, when the stage migrates, okay. And actually we were just talking about, even in normal breast cancers, the stage can migrate from stage 1 to 2 or 2 to 3 in about 2 to 3 months.
Okay. Yeah, so that's the huge impact. Like from stage 1 or stage 2, we are directly moving to stage 3. So my follow-up question for Dr. Bhargavi is: these are the cases, stage 3 cancers, which will typically require neoadjuvant chemotherapy also. So additional treatment also. Like if it was stage 1 or stage 2, the patient would have got a lumpectomy and radiation therapy. Now with the locally advanced, we are also talking about chemotherapy. So were similar trends seen at your institute too, Dr. Bhargavi? And a patient requiring limited treatment in the form of lumpectomy and radiation therapy versus neoadjuvant chemotherapy and surgery and radiation, how does it economically impact the patient?
Hello, thank you for the opportunity, Dr. Shilpa. Yeah, definitely. Whatever you yourself and Dr. Rupa had shared, it had almost a similar scenario we had in our hospitals too. There was a major difference in the stage at which we were detecting the breast cancer between previous to pandemic and during the pandemic. Most of the cases that we saw during pandemic and immediately after the pandemic were LABC. And prior to that, we were picking up a good number of early breast cancers as well as DCIS. But I can say it was a single-digit number that we were seeing last year. That is, during the pandemic, there were absolutely no screening whatsoever. Either there is a no-risk candidate or an increased risk with a familial risk, or patients with who are cancer survivors who were on follow-up or screening for the opposite breast. No one came. No one came during the pandemic, and they were more afraid of catching the COVID rather than getting a new thing detected in the breast. And another thing that we felt was most of the early breast cancer that we picked up either immediately before the pandemic or in the early days of pandemic, instead of getting an upfront surgery, they were referred to either a hormonal therapy or a chemotherapy because of the guidelines by the surgical oncologist and medical oncologist in place. They were referred for a hormonal therapy, or if in case of TNBC, they were referred for a chemotherapy. Yeah. What other problem they had was they were not having enough, MRI mammogram after the chemotherapy or hormonal therapy. Neither there was good amount of wire localization that we could do during the pandemic. And there was a period of, close to 2 to 3 weeks, there was an acute shortage of wires also. And we were not able to do wire localization that time, which, instead of women who could have undergone a BCS, but for the pandemic, they ended up getting an MRM. Yeah. And that happened because of, I feel, MRM, and that would have emotionally caused a difference to the women. Though it, from the oncological point of view, they may not say BCS and MRM anyway, they got rid of the malignancy. From the emotional point of view, it made a lot of difference to the women. So a BCS saw a dip during the pandemic and immediately after the pandemic because of the same reason. And LABC stage 4, I don't think there was any difference at all. Who were metastatic before, during, they were still metastatic and they were continued to getting that radiotherapy or chemotherapy or palliative surgery. They continued to get the same. But in between patients and other group of patients who were they were facing the brunt, where the cancer diagnosed women getting COVID. And their treatment was like even more prolonged. God forbid, if they had an asymptomatic or a mild case, they were able to follow up their treatment or further intervention within 14 or 17 days. If they succumb to it or, have a very prolonged COVID, they had to first get rid of the COVID, get treated for nearly 6 weeks, 8 weeks, then come back to cancer. And by the time they may not be even, GC may not be good enough to get a chemotherapy. Neither the surgeons were able to do a surgery. They were in, just like you started in the beginning, they were right in the middle of the tunnel, couldn't see light on either end. They didn't know what else to do. That we saw, but in spite of that, we were able to give the surgeon intraoperative ultrasounds we were able to do, so that in case we were not able to put a wire during the chemotherapy time in early breast cancers, we were able to still show them during surgery by doing an intra-op ultrasound with the surgeon. It saved a little bit, but I don't know, long term, we should see. Then second wave, though the numbers were huge, we didn't have any of such problems. We were able to tackle the situation under, much more under control.
Right. So experience helped the second time around.
Yes.
Like we were prepared. We knew what to expect. So which brings us to the follow-up question. So the trend that we saw was from women were waiting at home and coming to us with locally advanced breast cancers. That was one trend we saw. The second trend we saw was because of the surgical guidelines and because of the situation, there was limitation of resources also. Even in radiology, much of the resources were going towards the care of COVID patients. So in such a situation, they were being offered chemotherapy, neoadjuvant chemotherapy, hormone treatment until resources became available to have the treatment. Also, there was a financial impact. Now, not everyone in our country is insured. So people are shelling out money from their own pocket to get the chemotherapy and all that. So that is the third impact. But to follow up with your question, what Dr. Bhargavi said, I'm going to ask this question to Dr. Bhagyam. Dr. Bhargavi said that some of the patients who were undergoing treatment also contracted COVID. Okay, so that was also a real threat. It was not as if it was not there, but what is this benefit ratio, or how differently were we triaging patients in the first wave in 2020 as against the second wave in 2021? During the first wave, it was the fear of the unknown. We just didn't know what to expect. During the second wave, we were a little bit wiser, but it had spread like wildfire. So everyone was using their own experience, and case-based decisions were made in a lot of ways. So Dr. Bhagyam, could you please enlighten us how the difference went?
Yeah, to just give a perspective, mine is a cancer hospital, and we did not keep our COVID patients with us. We had a few beds which were isolated for COVID patients. So, so despite that, we had actually, if I had my statistics right, the average patient from March to August 2019 was around 49 patients, which from September to March rose to 144. And then this lockdown, we had a semi-lockdown starting in April first to 15. After that, it was a full lockdown. It was still 61.5. So that shows how prepared we are with COVID, how to deal with it. Not only that, earlier people wanted to avoid this community spread. The second wave, it had already reached all across the community. So people knew that this is something that they cannot this, and a lot of them had got vaccinated. So this was another big thing. Staff got vaccinated, and by the time this COVID came, we all had two vaccinations. So I was also not worried about putting my staff on strain, because we are usually at the head end of a patient. So even stereos are, when we compared it to last time, which was actually, we almost managed around 7 cases. We were able to do 7 cases. We surveyed, nothing. Like 7 cases post COVID and 8 cases. These are all monthly averages, and then nothing which was there. Now we are again doing 2 to 3. So you give women a better chance. But one thing that is really there is COVID has morphed into a wild animal, and to that extent I can say that we should take our precautions. I do not think, I have another hospital where we do up to 300 master health checkups, okay? And there it's highly volume driven. So that era will be forgotten, at least till the whole population gets vaccinated. So I think what has happened in the second wave is we have learned our lessons. We know how to deal with COVID and breast and cancer. And all cancers we found were, I have a PET-CT unit where all our cancers. Today I saw a cancer which the breast is popping out. There are 2 large bulky axillary nodes as big as the breast and metastasis. So we know the price that you pay for waiting. So patients are coming, we are able to handle better.
Right. So from what I understand, screenings will be stopped for now because of the widespread spread that we saw of COVID. But symptomatic patients, we are encouraging them to come in time with adequate precautions for our staff and adequate precautions for the patient as well, because it is in the benefit of the patient that the patient who is symptomatic has the mammogram, breast ultrasound, and the biopsy if required. Taking that point further, I would like to ask the next question to Dr. Rita. What is the risk versus benefit? Like, we have already discussed this a little bit, but what is your take about this? The risk versus benefit of getting investigated for breast symptoms, knowing that there is a potential risk of having a breast cancer, versus the potential risk of being exposed to COVID when a patient goes to a healthcare facility, because as it is, there is a higher incidence of coming in contact with an infected patient.
I feel you already have answered this question by Dr. Rupa and by Dr. Bhargavi, that there has definitely been a decrease in the cases during this COVID time. And then post-COVID, yes, patients have come with more symptoms, more growth in the tumor, more mass, axillary lymph nodes and all. But I feel that there has to be an option, there has to be something which we can give to the patients beyond just this. We can have stand-alone clinics for breast imaging where there are no COVID patients taken. So we can have communities, we can have a community call and explain to them that you need not go to these sections where there are COVID treated patients. You can go to the non-COVID standalone clinics and get investigated with a simple ultrasound or a simple mammography, and at least you know what you are there, and then you can go for further treatment higher on. So in this way you can prevent the spread or the growth of the tumor that is having during this COVID time when you are not reaching the location where you are supposed to go, and this way you can stop the spread or stop the further managements that they are going to wait for otherwise.
The fear of contracting COVID, they don't have the fear of contracting COVID.
We need to explain it to the community at the community level. I know one breast imaging, one of my doctors who is in breast imaging, she takes her community clinics or by online clinics and educates them that this is the way. Whenever you have some symptom or if you are just wanting to find out what is there, You can just go to such type of clinics and we can educate the patients, and then we can make a difference so that the patients do not come when they have a very large tumor with nodes or something. This is
Right.
my perception. Yeah.
Yeah. Thank you, Dr. Rita.
Can
So
I-
to now effect, bigger centers, tertiary hospitals have taken the step of having online consultations. Tertiary cancer centers are doing online consultations such that they can triage the patients. They can explain to the patients which patients need to come to the hospital for further investigations and which section of the hospital they can go to. But you made a good point here, Dr. Rita, that sometimes patients can't overcome fear and they want to go to standalone facilities. In that regard, I would like to direct my question to Dr. Tanvi, who runs a dedicated breast unit in one of the elite neighborhoods of Mumbai. So what is it that, Dr. Tanvi, you saw in terms of the difference in patient presentation during the first wave and the second wave? What were the difficulties that you encountered, or what were the patient perceptions that you had to deal with during this time?
Hi, everyone. Thank you for inviting me on this forum. Very pertinent question, Dr. Alad. So I have a standalone clinic in Mumbai, and we have it's a breast facility. So I do 3D mammograms, breast ultrasound, and interventions. So when the lockdown initially started, of course, we were grappling. 2 weeks we kept the clinic closed when there was a lockdown. But after that, we got all our precautionary measures, our disinfection protocols in place, and we took very stringent measures because we wanted to get back to work. Luckily for us, the good side is that all the screenings have gone down. Definitely, the total number of cases that we were seeing pre-COVID are much lesser than what we did in COVID. But my work in the standalone clinic is predominantly diagnostic. Even in the pre-COVID times, my work was predominantly diagnostic, where patients would come in for a mammogram with symptoms like whether it's lumps, nipple discharge, etc. My screening work is, let's say, 20 to 30% of my general work in breast imaging. Which was a good thing in the crisis. And another good thing was, like Dr. Rita said, that a lot of patients, the hospitals were full, especially during the peak of the wave, when there were no beds available, the ICU facilities were full. People were very reluctant and scared. They were hesitating to go to the tertiary care centers for, their breast symptoms. And that is where we came into the picture. I'm really thankful that people did approach us, and instead of waiting back, they would inquire whether you offer CT chairs. They would just, make calls and say, do you do CT chairs? Do you do COVID testing? And when we would say no, they would be like, oh, good, then we will come. So they were happy to approach us for this test, and we were very happy to do it for them. We had to take a lot of precautionary measures for that. We used to do telephonic screening, like during the time, when we give appointments to the patients, we would screen over the telephone. We would ask them for their symptoms, whether there was any travel history. Of course, we've had to stagger patients because we couldn't, club them. Waiting rooms, pretty much whatever people have been doing in all the hospitals, we've staggered patients over time. We've kept specific disinfection protocols in place, extensive cleaning of our equipment, disposable linens. All that had to be done. And that is very important for our staff, to keep our staff protected, our healthcare workers from our reception staff. Of course, now everyone's got their vaccines in place, so that's another good thing. So although the cases did decrease, like you showed in the initial, in your presentation, there's been an undulating sort of curve. There's been cases which, as soon as the lockdown is released, we see an upswing, and then if there is a peak again, it dips down. And biopsies, we have been doing all the interventions, even in the lockdown, even through the lockdown, but of course with the necessary precautions.
Yeah. So my follow-up question here is, Tanvi, you said that yours is a center that does not offer anything else but breast imaging, right? So in such a situation, when there is a dip and you are in a standalone center, there are other considerations. Like, unfortunately, we are not a completely 100% public healthcare system with government funding for every single institute, okay? Many of us are funding our own projects. Therefore, there are EMIs to go. Where there are no EMIs, there are at least CMCs for the equipments, which is insurance for the equipments to go. Salaries for the staff, they cannot be cut down on. Then there are overhead costs also, other overhead costs related to the premises. So in such a situation, would it be of any help if there was some form of government intervention? I'll give you a small analogy here. At the peak of the lockdown, the real estate was going to crash, and that would have been a big hit for the government and the economy. So the government took a preemptive step whereby the stamp duty and registration was decreased from 5% to 1%. And that helped sustain the real estate market. Okay, they did not completely crash. Okay, but that is a huge section of the economy. So government directs its attention to there very quickly. However, with preventive healthcare or private healthcare, such attention does not go until we bring the government's attention to it. So would it help in any way if the government gave some kind of redemption, tax redemption, or some kind of policy cuts towards centers such as this? So this is my question, and it is open to you and open to Dr. Rita and everybody who would like to contribute. How can we do this better? Because this is an integral part of our system. The private setups are an integral part of our system. And in this pandemic, we saw that just with the government setups, we can't cater to a population of 1.2 billion people. We need the private healthcare setups also, but for them to survive, is there any policies? Is there any recommendations, suggestions that we can make to the government? So I'll start with you, Tanvi. What is your thought? Because you're in the middle of things. And then I want to ask Dr. Rita, Dr. Bhagyam, Dr. Rupa, and Dr. Bhargavi in that order. What would their recommendation be, or what should we be suggesting, or as a community, as a medical community, what should our suggestion to the government be?
Well, first of all, when we buy such equipment, as you know, if we want to start a standalone clinic and you want to start it in this day and age, it's no use starting with analog. You have to, spend and take loans for these expensive equipments, because all the FFDMs cost a significant amount of money. And if you want to provide that service, you have to spend. Now, having said that, it would really help if the interest rates on loans are reduced significantly for doctors and professionals. During the pandemic, of course, considering that a lot of businesses were not even operational, we are lucky that at least healthcare was operational and we could manage. But and the government also provided a moratorium period, for the loans. There was a moratorium announced by the government from I think March to June, and then March to June, and then it was extended by another 3 months. So it was a 6-month moratorium that was given. But even if it is a moratorium, you have to pay it at the end. It's just that your time schedule is, pushed by 6 months or 8 months. So reducing the interest rate at that time would be something which would be very beneficial if the government were to consider that. I believe there have been pleas for this, but no decision has come down yet. And of course, doctors are not very high on their list of priorities, as you know, with so many healthcare workers being bashed even in the pandemic after the exemplary work that they've done. It's a little unfortunate that we need to not just bang our equipment and thalis and spoons, but we need to do a little more for our healthcare workers.
Yeah. So what is your take on this, Dr. Bhagyam? What is your recommendation or suggestion about this thing? You're muted. You're muted. Dr. Bhagyam, you're muted.
Sorry. I do agree with Tanvi that you can have a moratorium, but if you look at it, there will not be too much of a moratorium anymore. You have seen that the government has been very, very quiet, and we saw the finance minister last time almost every time, whereas now Mann Ki Baat is very silent, And it is true, because we have a lot of money to be spent on vaccines. Who's going to pay for it? So one thing that we can do is some of these excise duties and so many of these, maybe those can be reduced in some way or the other. And also for things like breast equipment, certain equipments where the businesses have gone down. See what has happened in lots of other centers which had CT scans. Okay, they did humongous profits, whereas standalone breast centers didn't do so. Maybe they can have as a society, maybe we can also present our case to the government and say that single unit people should be given some kind, and these are all in tier 3 cities, and also in slightly, in Bombay also, if they are there, they are in some locational areas, not tied to a hospital. So there, I think we should, make some presentation and try to see what we can do. That was one. Second thing I really wanted to say was, just those shortage of wire localizations was something so, pathetic. And, the whole of India, we didn't have wires and we were searching for it. So, next, whatever it is, if we had a channel to expedite certain things, because during COVID, it is understandable that people are going to give chemo. Okay, nobody is going to sit and operate a breast when you are having so much of COVID. The nurse can have COVID and she can give it to the patient. So definitely that is something we have to have a channel where our equipment is in place. Wires are life-saving equipment, or breast, not just breast-saving, because it is life-saving. It does reduce your morbidity and mortality.
Yeah. So exactly what Dr. Bhagyam said, what Dr. Tanvi said, that sometimes the government doesn't know because nobody has ever told them that such a problem exists. So it becomes our responsibility. They have only seen, like Dr. Bhagyam said, the city centers making a huge amount of money, okay, but they don't know the reality. These are life-saving things for the women of our country who are grappling with locally advanced breast cancer, who are afraid to go for treatment. And this is the section of the population, and this is the section of healthcare which needs protection. So, Dr. Rita, you have a background in law. I would like to ask you, if as a society we wanted to take this further, what is the right channel? Because we don't get an education in law or government policies, but we have so much to say. So what is the right channel and how should we do it?
I can personally think of some insurance policies where the women, particularly the women, are protected for, and they are being paid for this type of diseases like breast cancer. So this is the first.
Rita, I'm sorry. If I didn't bring my question forth properly, this is not just the first part is the patients, which we have been discussing, but the second part is protection of the standalone institutes, or channeling equipment required, like localization wires, equipment required for procedures related to breast interventions, which got hold up, or which could not come into the market simply because they were in some kind of government channel waiting for approvals, and therefore we could not use them. So all these kind of things happen, and we want a channel to make the government understand that anything related to breast cancer or as such should not have should not get held up in red tapeism, or should have some redemption in the form of tax benefit or some kind of channel. So how do we make channel for that? Who do we go to? How do we make ourselves heard?
Like, we have to first approach, as the Dr. Tanvi said, we have to approach the government and make them aware that this is the most important thing in a female's life, and it has to be tackled at their end. There are certain, like we had certain Sanjay Gandhi schemes or something. That way we can have certain breast schemes wherever these standalone clinics are providing. They are also being supplemented by government for each such case that they are dealing. This way they can help the patients, for the economic that they cannot bear, and at the same time they can help the center also, so that they can work in these times where it is very difficult to pay the loans whatever they have taken. So we have to make the government aware of certain schemes where they can help such type of centers.
Okay, thank you, Dr. Anybody else has any recommendations or suggestions related to this?
The other thing I wanted to say is, now with the second wave like this, and there is going to be a third wave, if I'm not mistaken, there are a few more cases which are seen in which are Bombay. Slowly you're getting more cases, slowly, very, very tiny drips are there, and we know how this will escalate. So we are going to get waves and waves of this. So why not be greedy and have so many mammos? Like, I know that we used to do like 100 mammos. So now, we should be prepared for COVID as a way of life. Have masks, have, social distancing, and start your screening. I have not denied any patient for screening now. particularly when I'm having patients who are coming. That's why my numbers, I was also surprised. Oh, I've done so much. I've done work even during this pandemic. Last one I didn't. But the problem was this time patients were more afraid to come. Though we didn't close the department, patients were more afraid. So I think we should say that COVID is here to stay. We have to grapple with it and do the screening, not at like 40 cases every day, which we used to do, like 35 cases. We used to do 40 at one center, one of our centers. Now just stop it and make it like 20, and try to have social distancing and, get on with our lives.
Yeah, that's a very good point. But to do that, what would we like to tell our audience? Like most of us sitting in this panel here, knock on wood, we have been out there in the thick of things. And despite of that, seeing patients' relatives, none of us have gotten COVID. So what is that one thing we followed religiously so that we did not get COVID? And that is what is going to give our patients confidence to come out. So in my case...
Don't be too soon. Nazar na lage. But
yeah,
okay, I am guilty of that. I have contracted COVID and I have recovered by the grace of God. But
okay,
even I had COVID and I have recovered
so which is great news. But I would say I would like to share a few tips and tricks, and every one of us has been trying different things. One thing, we made sure that we wore N95 masks all the time. The three technologists who are constantly doing mammos and helping in the ultrasound room, they were also provided with N95 masks. And my transcriptionist who sits in the same room as me. So these are the 5 people who were properly sat down and explained that, this is an airborne disease and it spreads through droplets. So this is how we can protect ourselves. And these were the people who, despite of handling patients, touching patients, not knowing who's an asymptomatic carrier, were, by God's grace, spared of COVID. So is there something similar that each of you have been doing and you would like to share it with our audiences so that they have the confidence of coming when they have a breast symptom and not waiting at home until things get out of hand? So I'll start with Rupa again. Dr. Rupa, would you like to say something?
Yes, exactly. So we also were very sad that in the first wave and the first lockdown that our screening mammograms came down significantly, because we have very active health checkup department, and we had actually looked at our numbers, and we were actually at one point picking up in every 1,000 cases, we were actually picking up to 4 to 5 cancers. And once we actually went on to tomosynthesis, we were actually picking up 6 to 7 cancers in every 1,000 screening women we did. So we were actually picking up a lot of cancers. We were doing 500 mammograms per month. So we were thinking, oh yeah, we are actually picking up 2 to 3 cancers every month of asymptomatic women. And then when the lockdown came, and then we actually ended up doing about 20 or 30 mammograms every month, we said, what has happened to all those 2 to 3 cancers which we should have picked up in this month? Are they just lost forever? So we also immediately, as soon as we could, we went back to screening. We had put up a lot of flyers, a lot of banners telling them. We had gone on to social media. Our hospital also had put on a lot of videos, and we had actually spoken, saying that you should be coming up for any test which you require, for your health. Please do come. And actually, a hospital is actually the area where you are least likely to get COVID. This is my personal appearance. I think it's true, because most of the COVID patients are separate. Everybody who comes in contact with you is fully protected and fully vaccinated also. All our equipment is cleaned and disinfected, as Tanvi said. So the chance of you getting COVID during a test is much less than the chance of you picking up something which will affect your life. That was the sort of thing we were trying to put forward. We did succeed to a certain extent. I think in the second wave, people actually got more used to COVID. As you said, a lot of people had been vaccinated. They were more things, so they did come up. So I think a lot of patient education and actually even doctor education had to go forward, and that took some time. So the first wave, we actually lost out, but probably during the second wave, because of the the acceptance of people, the fact that a lot of us were vaccinated, people did really come back, and screening did start again, and it's not as good as it was before, but we are picking up those early breast cancers again. I'm happy about that.
Excellent, excellent. So were you advising all your patients to wear masks and come and
yes,
go ahead?
Definitely. No patient is allowed inside Manipal Hospital without a mask. And we have, a lot of people going around telling people, please, continue wearing your masks. You have people, they'll start the phone and then they'll take off the mask while they're on the phone. We say, no phoning, no unmasking in the premises, always with the mask. Okay. And we have all these banners. We have, on the TV, the LCDs also that keeps coming up. Please keep your mask on. Please keep your mask on. We had social distancing in the form of having one seat and two seats in between sort of blocked. So, you couldn't sit next to each other. You had to occupy the fourth seat. Okay. So we had things like that. And that has worked. That I feel really has worked. It has got people in.
So from your point of view, Dr. Rupa, education has been done on two fronts. One is, please protect yourself, wear masks and when you come to the hospital, follow the COVID protocol of social distancing. And at the same time, you've also educated the patients that if they have breast symptoms, they are not to stay at home. In fact, if they are up for a screening mammogram, they should also come for a screening mammogram. So that with all the adequate precaution, because it is actually life-saving. So that is a great message. Dr. Bhargavi, are you doing something similar at your hospital, or is there similar protocol being followed, or is there something additional that you're doing?
Almost we follow whatever Dr. Rupa was also enumerating. We were calling it a new normal days that we have a set of protocols that we follow in between the two peaks, which we continue to do even during the second peak as well. We were staggering the appointments, and as Dr. Tanvi told, we were doing a telephonic consultation with the patient regarding the symptoms, and we were encouraging them to come to the hospital. We made sure that the COVID and non-COVID symptoms patients were completely segregated. We were treating even COVID patients in the hospital, but we made sure that none of them come in contact with the non-COVID patients related symptoms, like women and children. They continue to have their own problems, and they come to the OPD, and we have completely segregated them. And as in most of the hospital, there is a fever clinic. Patient go and see if they have any suspicious symptoms, and they don't come to the non-fever or non-COVID related illnesses area. And we also encourage the women to get the screening done even during the second peak. What we found the difference was still the asymptomatic women undergoing screening didn't happen in the second peak too. But the follow-up of BIRATS 3 lesions, they came. They came during the second peak, because we had told them the SOPs in place and not to worry. And the technologist was continuing wearing the PPE, irrespective of whether the positivity rate is 5 or below 5 or 0.1 or whatever the current status. We continued wearing the PPE. We were looking like aliens, and patients were thinking, now COVID is not there. In December and January, you should have seen them sometimes arguing with us, but we said, no, we are on the safer side. We still have not been vaccinated, and we don't want to take risk whatsoever the positivity rate is. And that proved helpful for us. And PPE we were continuing to wear, and I asked the technologist also to wear eye goggles and other stuff, face shield and everything. Patients, as ma'am told, without mask, no entry. Please go back to your house, or go back to supermarkets, wherever you want to go. But inside the hospital, you should at least have a decent mask. And during interventions, we made sure either they get an N95 or at least wear a double mask, because they'll be in contact with us for a longer time. And that's it, ma'am. Pretty much whatever other hospitals were doing, we were having the same thing. Just I need to add.
Yes.
The other thing I said was,
Bhagyam, coming back to you, during the first wave, we were asking for RT-PCRs for our patients, because we were also grappling with something that we didn't know. But during the second wave, we saw that we were more adept, and we knew that with personal protection and a certain amount of protection for the patients, we were in a better position to offer them the imaging as well as interventions without having to go through any RT-PCR test. So do you suppose that during the second wave that also helped to a certain extent?
No, the second wave, I thought I would do the RT-PCR, okay, because of this new strains and all that which were coming. That was the least. If people are for flying, they're taking the RT-PCR. When I'm sitting with them for half an hour biopsy, if I found a large mass, which I'm going to do in 2 minutes, then even if they were a walk-in, then I would just do it. It was totally my decision. And if they're coming from very far away and she's old and she has a huge mass and I can just finish it in very quickly, then I would just not insist. But small lesions, stereotaxy, where I'm going to spend more than 20 minutes figuring out stuff, I definitely think that we should continue to have some form of you should have the RT-PCR for the sake of your staff and the strains which are happening. That is the reason.
Okay. So that is one way of thinking about it. And how have you been?
I think we should vaccinate.
Vaccination. Yeah. So like the Spanish flu in the 1900s, early 1900s, lasted for about 2 years. We can just hope that COVID is one of those things, and it has a timeline of about 2 years, and it just goes away with the vaccination and the community. The herd immunity that comes in. But in the meantime, from the discussion that we have had by our elite panelists, we can come to a few inferences. One is that during COVID times, patients have been reluctant to come to the doctor for breast symptoms because the fear of having COVID is far more than the fear of having breast cancer. Eventually, when they were coming with locally advanced breast cancers. So we want to turn that around for the sake of our women, right? We want to bring this to their notice that with adequate precautions, please, if you have symptoms, come to the doctor, get yourself investigated, have that telephonic conversation, that having that triage person in between who is a trained person in giving appointments, finding the patients who need to come to the hospital, that kind of a thing. The second point that I get from our panelists is that even if you are not symptomatic and if you were regularly screening yourselves like you should be after the age of 40, please don't stay home. It is time. Like almost for 2 years, you have not had a screening examination, and where we were catching about 5 to 6 cancers per 1,000. What is happening to that women? They are getting endangered towards the possibility of having LABC. So please, if you do not have any symptoms related to COVID, this is a good time to come get your mammogram done, albeit with adequate precautions. Like Dr. Rupa said, don't pull your mask down to talk on the phone. This is not the time to talk on the phone. Just zip in, zip out through the hospital or to the centers so that you can get your mammogram done. Because at the end of the day, the earlier we catch it, the better survival chance is there for our women. And the symptoms that we are talking about, in the audiences, if we have women who are wondering what are these symptoms they are talking about, there are 3 top symptoms that we try to explain to our patients. If you ever have a painless palpable lump in the breast, or if there is new onset nipple inversion, or if there is spontaneous bleeding or watery discharge from the patient, from the nipple, or there is skin changes, skin thickening or skin dimpling, those kind of changes, then please go to your doctor. Okay, there is typically no pain in breast cancer, so don't wait for pain to arrive. Don't tell yourself kuch nahi hoga, theek hai, aage ka aage dekh lenge. No, see your doctor. Okay, because when you save your own life, when you go to the doctor in time, you are in a better position to take care of your dependents. Okay, so with that, I would like to open the panel to all our esteemed panelists. If you guys have anything else to contribute, then. That would
the
be great.
other thing I just wanted to say was I found it extremely useful if I gave my phone number to the patient and I talked directly with them, WhatsApp them. Sometimes if I was busy and they call, I'll say, I'll call you back. And then, you save them the trip to come. And you also, feel less guilty, and you're just not waiting. So a lot of times that really helped. And most patients were very, very nice about it. And they said, oh, you're not coming today. It's okay, you come tomorrow, so that you avoid that. And that has something really, triaging is also helping. And I think governmental thing, we should help, we should push. I think at IRIA and IRIA level and BC level, we can make a memorandum and then, put it across so that we can help the patient. help ourselves to help the patient.
Yes, yes, that's right. So, with that, I would like to hand over to Hemangi. And if there are any questions from the audiences that you would like to put forward to us, the panel is open for question answers from the audience.
Yeah, thank you so much. It was very nicely summarized, Dr. Shilpa. And we have we'll have questions, I think, but we have shared on the other portal. So I think they can mail you all the questions if they have any query. So
if there are one or two pertinent questions which you would like to ask the panelists, they would be happy to take it. We still have 2 minutes to go.
Yeah, actually, in fact, I have one question. It's like, if patients, I mean, basically, like us, we will not be able to know whether, whether I'm getting any kind of symptom, right? Maybe lump there. That can be a very normal thing, but how would I know that if it is getting severe or something? I would not be able to know, right?
Exactly,
So
that's the reason why you should show up to a doctor. And that's the difference between a screening mammogram and a diagnostic mammogram. When we say screening, it means that you have no symptoms, but you have that little niggle or worry in your mind. I hope I don't have the breast cancer. Therefore, you get the mammogram done once a year or at least once in 2 years. However, when we say diagnostic mammogram, which means you have some form of symptom, pain, palpable lump, discharge, skin changes, it could be anything, but you are not in a position to know whether this is serious or not serious. Therefore, even in this situation, you are supposed to go to your doctor. And this is exactly what this esteemed panel is trying to convey to our audience.
Correct. And I think there are many myths related to this mammogram and the sonography and all, that it can hamper your health, or it have side effects or anything. So I think many females, they usually they don't go to doctor in this fear only that
Yes.
it might affect the health.
Yeah, like Hemangi is asking us two things. One thing that our patients constantly ask us is there pain associated with a mammogram? Well, there is pain, but it is minimal. And I would call it discomfort. It lasts only for 7 seconds on each side. And you women go through labor for 16 hours and you're scared of pain and compression for 7 seconds on each side. That compression could actually save your life. So don't be afraid of that compression. And about the radiation, I can tell you the radiation involved with a mammogram is minimum, okay? 0.0004 grays of radiation, okay? 1 gray is equal to 1000 milligray, okay? So it is a fraction of radiation. And the kind of radiation that causes harm is above 5 grays. To give you some context, in Hiroshima, Nagasaki, the amount of radiation that was given was about 9 grays. Okay, so to reach that level, 5 grays of radiation, the woman would have to have 12,500 mammograms during her lifetime, which she will never have. So I promise you, we don't bomb the breast in those mammography suites. Okay, it is bare minimum radiation, and it is not going to harm our patients. We are here in the best interest of our patients. We would not have got any FDA approvals if this radiation was bad. So women, please don't be afraid, neither of the compression and pain nor of the radiation. You get more radiation from this just walking in the sunlight for 7 weeks. You get more radiation than this if you're on one flight from Mumbai to London. Yeah. And people are not afraid of traveling in our country anymore. Like my patients, every third patient is traveling to Dubai, to New York, to London. They never ask this question, what about the radiation? But when they come for mammography, they have this question, what about the radiation? Aisa kaise chalega? We have to save your life. No, please help us save your life.
No, it's
right.
Well said.
Yes, Dr. Bhagyam, you were saying something.
No, I said it's very true. Sometimes our worst culprits are some of our own co-colleagues in oncology. Today, why it happened was, I was suggesting that we should do a contrast mammogram for a patient who had one side breast cancer and there was a doubtful lesion. And the oncologist oncologist, okay, was, oh, she will get radiated. This is for a decision for breast conservation, where you're going to anyway bombard the breast with radiation. So
Exactly.
I understand the myth, why there is so much of a misconception, but I'm so happy that you all as a forum have brought us all together to, completely try to educate. And this we will do every time, all the time.
Thank you. And
Just,
there is
can I
one more
just
question.
add one point?
Yes.
Can I add a point? Yeah. So
Yeah,
anyway,
sure.
about radiation, some people, Shilpa gave a good a reply to give to people who ask about radiation. Sometimes what I tell people in Bangalore, I said, you have a vehicle in Bangalore. Now, isn't there a theoretical risk when you take your vehicle out in Bangalore that you can have a very bad accident and actually die? There is, right? But the benefit of you having your own vehicle and driving it in Bangalore is far, far, far higher than the risk of you dying because of your vehicle. So you will use your vehicle, but you will use it wisely. You will use it using the rules which are provided by the traffic police. And that's exactly what we are doing. We are giving you some radiation. We're not saying it's totally harmless, but the benefit of you picking up a breast cancer and actually saving your life is much, much higher than the theoretical risk of something happening to you because of that small radiation. So that's another way of putting it across to them.
Yes,
The risk,
that's a good analogy.
benefit of you getting is far, far, far higher of any risk you have because of that radiation.
And I think there is one more question has come up. Like they have asked any precautions a pregnant lady can take. I mean, what if she has any symptom or something, what kind of precautions she can take, and what she can go for, and what she has to prevent. I mean, she can.
I understood the question. Like, during pregnancy, if you get breast symptoms, what should you do? Is the question.
Yes.
So it's the same thing as that during non-pregnancy. Okay, the chances of having benign lesions is far higher during pregnancy. It could just be normal breast tissue for all you know, because the breast, due to the influence of hormones, changes during pregnancy. But there could be something like a fibroadenoma or a lactating adenoma, some benign lesion. However, there is still a risk of a pregnancy associated breast cancer. It is not zero. A condition called pregnancy associated breast cancer exists, and we don't know whether that woman with a new onset palpable lump during pregnancy has a benign lesion or it is a pregnancy associated breast cancer. Therefore, that woman also has to go to a specialist doctor. First, she goes to her gynae doctor, then the gynae doctor refers her to a specialist doctor to get her evaluated for that breast lesion. And appropriate evaluations are done, starting with a breast ultrasound and anything more if there is suspicious findings on the breast ultrasound. Yeah.
So I think we have got all satisfactorily all the answers we have got. So I think we have got the best panelists today, and many viewers, they have got so many answers to their questions. So thank you, all of you. And with this, we'll end our session here. But before that, we have certificates here for all our eminent panelists who are here. So I would like our team to present the speaker certificate. Dr. Shilpa Lad, Consultant Breast Imaging and Interventions, NM Medical Center. Thank you so much for joining today. Dr. Rupa Anantasivan, Consultant Radiologist, Manipal Hospital. Thank you so much, madam. Dr. Bhagyam Raghavan, Senior Consultant Radiologist, Apollo Specialty Hospital. Thank you so much, Dr. Bhagyam, for joining today. Dr. Tanvi Jaki, Consultant Radiologist, Memocare. Thank you so much, Dr. Tanvi Jaki, for joining today.
Thanks.
And Dr. Rita Dhruv, Partner Prabhat Tele Solutions LLP. Thank you so much for today in this important session. And Dr. Bhargavi Venkat, Radiologist, Koshish Hospital. Thank you so much, ma'am, for joining today. And with this, we'll end our session here. Thank you all eminent panelists for joining today. And this has been a wonderful panel of today. Thank you.
Thank you very much.
Thank you.
Thank you all.
Thank you.